Welcome to our second workshop in the Impact Wellbeing Guide series. Today, we will be talking about fostering a safe and supportive work environment. We have an exciting agenda to go through today. We'll be starting with welcome and introductions. Then we will talk about being all in for improving health worker well-being. We will discuss Action 3 and Action 4 of the guide. Break down barriers for help seeking and communicating your commitment to professional well-being. We will end this series of this workshop with a facilitated question and answer session. Please note that today's session will be recorded and will be publicly available on the Impact Wellbeing website. So I'd like to start with the introductions of our presenters today. Myself, Steph Simmons. I am the Chief Medical Officer for the Dr. Lorna Breen Heroes Foundation. And the Lorna Breen Heroes Foundation and CDC NIOSH partnered to create the Impact Wellbeing Guide. If you'd like to learn more about the Dr. Lorna Breen Heroes Foundation, the link to our website is in the chat. I'll also love to introduce today's speakers. They are a wonderful group of people. As I introduce them, I will not be using titles to emphasize really that we are all working together in this work and to model the culture that we want to promote in terms of equity between healthcare worker types as we go through this work. So I have with us today Daniel Blaney-Cohen from the American Medical Association, Joel Bundy from Centera, Corey Feist from the Dr. Lorna Breen Heroes Foundation, Bethany Friday from Wellstar Douglas Medical Center, Abraham Segrist from the Virginia Hospital and Healthcare Association, and Jeremy Wooten from Wellstar Douglas Medical Center. Welcome to all of our presenters. To briefly recap our first workshop, NIOSH, in partnership with the Dr. Lorna Breen Heroes Foundation, developed the Impact Wellbeing Guide, which includes 6 actions that hospital leaders can take to improve professional well-being. The guide was real-world tested in 6 Common Spirit hospitals across the U.S. this past July through December 2023. The guide then went through a lengthy revision process to incorporate Common Spirit feedback for greater clarity and to provide a wider range of tools and resources. The guide is included in the overall suite of materials available as part of the NIOSH Impact Wellbeing campaign. So there will be 2 links in the chat. One is about the Impact Wellbeing Guide, and the other is to learn more about NIOSH. And I encourage you, if you haven't already, to download the guide and follow along as we talk about the different parts. Today, we will be featuring 2 of the actions of the guide, steps 3 and steps 4. The guide includes 6 actions and are intended to be performed in order. The first and second actions were reviewed in the last workshop, and the 5th and 6th actions will be reviewed in the 3rd workshop in this series. So before we dive into actions 3 and 4, which are the focus for today's session, we wanted to share briefly what was discussed in our first workshop in case you were unable to join us 2 weeks ago, so you can better understand how these actions build on one another. So action 1 and 2 were developed during the last workshop. And during the session that we had, a general theme that came up was that professional well-being work within a hospital, it's really key to have leadership buy-in as we do this. And so during action 1 and action 2, we really talk about understanding what's currently happening in your hospital or health system. So in action 1, the organization is going through a discovery process of what is happening currently. This is meant to really act as a foundation to the well-being work and to help current leaders understand what's happening. There's an opportunity as well to really understand what's happening throughout the organization and to hear the voices of different groups that may be involved in professional well-being work. In action 2, an organization builds a professional well-being team that leads the efforts in the hospital to support professional well-being. We described 3 different team models, and we really discovered that there were multiple models that you can move this work forward with. Even if you don't already have an executive leader to lead the well-being work. So as we move forward to discussing actions 3 and 4 of the guide, a primary theme of both is that we need to listen to healthcare workers about what needs to change. And we've heard that licensing and credentialing questions pose a significant barrier to help seeking. So we're going to start this session with a conversation about this, and then we will dive deeper into action 3 and 4. I'd now like to welcome Corey Feist, CEO of the Dr. Lorna Breen Heroes Foundation, and Daniel Blaney-Cohen, Senior Attorney at the American Medical Association, to the stage. Corey and Daniel, welcome.
Thanks for having us.
I would like to start with a question for Corey. Corey, how did you become aware that the invasive and stigmatizing language on licensing and credentialing applications was an issue for healthcare workers?
When I spent over 20 years in one large academic health center as a lawyer and as the CEO of the medical group, I never heard about this. When I heard about it was tragically upon the death or just before the death of my sister-in-law, Dr. Lorna Breen, the namesake of our foundation. When Lorna had been hospitalized for the first and only time in her career, she began for mental health treatment. She began to articulate her concerns around the loss of license and credentials. This ultimately was the last thing she really told us before she took her life, April 26, 2020. Subsequently, we heard from thousands of health workers across the workforce about the similar concerns that they've had. I guess it was about a year and a half ago now, I'm losing track, even the American Hospital Association published a suicide prevention guide in collaboration with CDC, identifying 3 key drivers of suicide of health workers. This concern around stigma and the loss of licenses is certainly is actually the first one they list. So we've heard this echo chamber now repeatedly. We've worked with the AMA, with the Federation of State Medical Boards, with the Hospital Association of Virginia, the Medical Society of Virginia, and really many, many other organizations to try to eliminate this stigma. And we've been really, really fortunate to have Daniel Blaney-Cohen's legal advice and his expertise and the support of the AMA as really to partner with our organization, really completely transform the landscape and eliminate all of these overly invasive questions which ask applicants about their prior mental health diagnosis and treatment. So with that, I'll hand it back to you and you can go to Daniel.
Thank you, Corey. Daniel, when did the AMA create their policy around healthcare worker mental health questions on applications?
Thanks, Steph. The policy itself, and for those who are on the call who might not understand AMA policy, AMA policy is set by physicians, and specifically the nation's medical societies, the state societies, the specialty societies, our medical students, our resident and fellow section. And so, during the pandemic, it was clear that all healthcare professionals and including physicians were faced with new stresses and an unprecedented level of circumstances that caused numerous outcomes, many unfortunately many adverse outcomes, and as a result of that, one of the things that the AMA tries to do is reflect what physicians need at the policy level, at the clinical level. And in that 2020, 2022 timeframe, there were a number of new policies that the AMA established to try to address healthcare professionals and physicians' wellness issues. And our policy on the broad scope, goes back, 30, 40 years. But this unique issue about medical licensing and credentialing applications arose because medical students, residents, and physicians told us that they were not comfortable seeking care for their health and wellness because they didn't want their employer to find out. They didn't want medical boards to find out. And as a result, they would not seek care. And things would tend to snowball. And, Corey and I are lawyers. So, we tend to, when somebody tells us there's a problem, we try to address that problem as directly as possible. And that goes, for the AMA as well. And, we're grateful for the partnership of the foundation and so many others, as Corey mentioned, just a small handful of the partners here. So with that policy in hand, and I'm sure we're going to go more into that. But with that policy in hand, we've been able to reach out to even more, including I was noting, multiple systems, hospitals and health systems that are on this call today, who we've worked collaboratively with to reform those questions to better support physician and healthcare professional health and wellness.
Thank you for that background. How has the credentialing reform become part of the Joy in Medicine program through the AMA?
I think the broader Joy in Medicine program seeks to identify all of the different, many structural barriers that physicians face on a daily basis, ranging from prior authorization and other utilization management barriers to conflicting payment mechanisms to some of the burdens surrounding with electronic health records. To all of the different regulatory requirements and payment issues, the new technologies, inbox volume, all of those different stressors, and one of those and so trying to attack all those pieces in a big program that we call the Joy in Medicine program. And this past year, it was added as one of the other components, the credentialing reform to that program, and we're excited that it is. It is a part of AMA policy, and we are looking forward to moving forward with more hospitals and health systems.
Thank you, Daniel. Corey, as we think about the healthcare workforce, we've heard that licensing and credentialing is important to physicians. How does this impact the rest of the healthcare workforce, and why should they also care?
We have learned, and really, frankly, we've spoken with thousands of licensed health workers in this country, whether those be pharmacists, physician's assistants, nurses, doctors. And uniformly, the lack of clarity about the consequences when they obtain mental health treatment alone is a barrier, and there's a presumption that there will be negative consequences. There are, in fact, negative consequences in many cases from a licensure perspective. But if you think about all of the different licensees in this country in the healthcare professions, they all either have these questions real or perceived, and many of these perceptions are reinforced and begun in the earliest days of training and education. But this is really a universal issue for healthcare workers. And when you think about the fact that now the CDC, as of October, has declared a mental health crisis among health workers, we need to clear the decks of all structural barriers that would prevent or inhibit a healthcare worker from simply taking care of her or himself the way that Daniel or I can, without jeopardizing our legal license. So I think this is a ubiquitous issue. The other thing that I would say, and I've said this many times, for an organization to make these changes, it often can be done very, very quickly. We have a shining star example of that on your panel, and so I won't steal his thunder. But I would say that in any change initiative, organizations are always looking for that low-hanging fruit or that high-impact, low-effort. And what we found in progressing through Virginia and other states, both from a licensing and credentialing perspective, is that these changes can be made with much less effort than the positive impact that can inure. And so we need to remember that. The last thing I would say is we need to understand that the enduring part of this work, beyond the change itself, is making sure that the healthcare workforce overall simply knows what the rules are. My sister-in-law's story is a tragic example and a tragic reminder of that. her license in New York was never in jeopardy. Her credentials were never in jeopardy. Yet as a physician of over 15 years in that singular health system and in that one state, she did not know what the rules were. And we hear this over and over and over again from the families of those who've been lost to suicide. So remember that this change piece is the first part. It's this enduring communication piece. But what better way? I can't think of really a better way for health systems right now to wrap their arms around the workforce and say, we value you, we see you, we care about you, than to make these changes and let the workforce know that they are valued and supported and that they can obtain any needed mental health care without fear of professional repercussions.
Thank you, Corey, and thank you, Daniel. I appreciate your comments, and it's a really great way to set our step 3 discussion. So I appreciate that, and the applause coming up the right-hand side of the screen.
Thanks for having us, Steph, and thanks for all you all are doing. I should also just end, Steph, as you're saying, there are many people on this line. I've seen your names. You've been working and softening the ground for this work for a long time. So thank you for helping Daniel and me and all the others really make this national change happen and become a reality. Thanks, Steph.
Thank you. Take care. All right. As we move on, we're going to discuss action 3, breaking down barriers for help seeking. We're going to get granular as to what that looks like, and then we will be having another discussion from organizations that have made this change. So in action 3, breaking down barriers for help seeking, we'll be talking about the process of reviewing and updating your hospital credentialing applications and identifying confidential channels for support for healthcare workers. There is a link to action 3 in the chat so that you will be taken directly to that online if you'd like to follow along. And there's also a QR code on your screen. So the key concept here is that intrusive and stigmatizing language on hospital credentialing applications prevents healthcare workers from seeking help. We know this from listening to healthcare workers that this is an issue. And removing this barrier sends a clear message to the healthcare workforce that the hospital or the health system supports their mental health. So the action item for this step is to audit and change, if necessary, the hospital credentialing application questions, and to determine if your healthcare workers at your organization have options to seek free and accessible mental health care. After this step, the expected outcome would be a completed audit of your credentialing application questions, updated questions if needed, and to have identified or developed those confidential channels. There are resources that are provided in this section, including a checklist to audit your credentialing application and a guide to update and remove intrusive or stigmatizing questions. And as you move through the guide, you'll see that this checklist is included, as well as the guide to updating and removing intrusive and stigmatizing questions. So on the checklist, it runs through some of the main areas of the questions of the credentialing application to review and to really take a look at, so that you're aware of. There's an how to use the checklist as well, that sort of goes through what you should be thinking about and asks you to reflect on what the unintended consequences of those questions might be. I encourage you to put your questions in the Q&A section of the app as they arise, as you review these sections along with us. The link for the checklist is in the app, as well as the link to the guide on how to remove the intrusive and stigmatizing language. As we audit all of the credentialing applications, addendums, and peer review forms, there's a few things to look for. The first is just to put a fine point on what you're actually looking at. You are looking at not just the credentialing application, but the renewal application and any peer review or peer reference forms that may be included, and any other addended forms. These questions, these are the forms that are most likely to have invasive or stigmatizing language about mental health care. And you're looking for the following. You're looking for questions about mental health that go beyond current impairment and contain invasive or stigmatizing language or a disclosure request around a clinician's health or well-being. Questions that ask about time off or breaks in practice that include language that reference mental health explicitly or in any way that is not supportive, and questions that ask about any past usage or experience beyond current impairment. There's also, you want to look for unnecessary asterisks or fine prints. Indeed, if they define current impairment as an actual look back time period to sort of make sure that the language is looking at current impairment and is supportive of seeking care. So there are occasionally states that will have a state credentialing application. So in those situations, hospitals and health systems have two steps that they can take. First, they can change their peer reference form to eliminate this language. And then they can also advocate at the state level to have their state credentialing applications changed. In the chat, there is a link to the Dr. Lorna Breen Heroes Foundation Licensing and Credentialing Toolkit, which can also be found within the guide. It walks through specific examples of language and how that change can look. So when we think about how to change the invasive or stigmatizing questions about mental health, there are really three options. In option one, there's an opportunity to ask one question consistent with the Federation of State Medical Boards recommended language that addresses all mental and physical health conditions all at once with no added explanations, asterisks, or fine print. And so this really asks, are you currently suffering from any condition which you are not being appropriately treated and that impairs your judgment or would otherwise adversely affect your ability to practice medicine in a competent, ethical, or professional manner? It is a comprehensive question about current impairment that does not single out or stigmatize mental health care. Option two is to refrain from asking questions about an applicant's health altogether. And option three is to implement a positive attestation model like those used in North Carolina and Mississippi that use supportive language about mental health from the board and holds healthcare workers accountable for their professional well-being, making the link between their self-care and their patient clear. And also to offer safe haven non-reporting options to healthcare workers who are under treatment and in good standing with a physician health program or other appropriate care provider. So each of these three approaches are acceptable ways to remove invasive and stigmatizing language in applications. So we're going to take a quick poll here. We know that not all hospital staff are credentialed healthcare workers, but many are still hesitant to seek care. So because of this, Action 3 also recommends additional ways to break down barriers to help seeking through identifying confidential channels of support. So we're curious, which of these three strategies is your hospital actively working on? Identifying confidential channels of support. It is strongly encouraged that hospitals provide alternative support outside of their hospital network. This could be confidential care through a different hospital or an unaffiliated online platform. Your hospital should secure a confidential option and share this information with staff. With regards to normalizing mental health challenges, when hospital leaders share their challenges and experiences of needing mental health support, it sends a powerful message to staff. The best way to share this experience is person to person, and you could mention something you've gone through in conversation or stand up at grand rounds and share how you got through an emotionally taxing case. And then lastly, as we've discussed, changing your credentialing application questions. So using the checklist to audit, change, and then communicate that change to the healthcare workforce. and to maximize efficiency, reviewing all of these forms together so you can identify which need updating. So it's the fear of judgment that's associated with talking about and seeking mental health care increases the risk of suicide among healthcare workers. Stigma is one of the prime drivers here. Staff may not access the resources that they already have access to or seek professional help for mental health care for fear of damaging their career. And it's important to remember that when we talk about these barriers, that we communicate it in such a way that promotes and encourages staff to get the help they need. And so we actually have a link in the chat for tips about stigma-free ways to talk about mental health care. All right, and we can see what our result is on the poll. And it looks like hospitals are working primarily on normalizing mental health challenges and identifying confidential channels of support. Lots of opportunities to work on changing the credentialing application to be consistent with best practices. All of these areas are critical opportunities to remove barriers to mental health access. All right. So at this time, I'd like to welcome Joel Bundy and Abraham Segrist to discuss the importance of breaking down barriers to help seeking and how hospitals' professional wellbeing teams can remove intrusive mental health questions from credentialing applications. Joel and Abraham, welcome.
Hi.
Steph, thank you.
It's a pleasure to have both of you here. And you are both from the Commonwealth of Virginia. There has been a statewide effort to removing barriers to help seeking in Virginia. And Joel, I was wondering if you could start off by sharing with us, why did Virginia commit to removing barriers to help seeking?
Great question. Thank you, Steph. It's something that we've known we need to do for a long time. We've all seen the Medscape report year after year. It seemed like it got worse. During the pandemic, many of us struggled. I think that for us in Virginia, there was a singular event, and Corey spoke about that with the suicide of his sister-in-law. And I think with that, we have a very close-knit group of healthcare workers in Virginia between the VHHA, which Abraham belongs to. I'm the CMO of a healthcare system with 11 hospitals, the Medical Society of Virginia, the Virginia Nursing Association. All of us recognize this was important. I think that what we saw during the pandemic galvanized us to take that next step and to move forward. And it was great because we had already been talking about this, and with that, we got together as a group, all the healthcare systems, physician leaders, nursing leaders, and Abraham's leadership on that with Corey and the Dr. Lorna Green Heroes Foundation. And we put out a plan. Before it was like boiling the ocean. The beautiful thing about this is like there are specific tactical things that we could do. I think that we'll talk more about it later, but I think those are the issues that galvanize us to move forward.
Thank you, Joel. Abraham, as this was coming together, tell me, how did your organization play a role in this commitment by Virginia to remove barriers to help seeking?
Yeah, two things actually came together for us here at the Virginia Hospital and Healthcare Association. We have a longstanding commitment in Virginia to do quality and safety together. We acknowledge that hospitals compete on a number of things, but over 10 years ago, our board said we were not going to compete on quality and safety, and that quality and safety improvement was a joint imperative for our field. And so we've had that as a longstanding culture. As Dr. Bundy referenced, during the pandemic, we became very aware of the need to take care of our caregivers. And we actually discussed at one of our board meetings some information coming out of the National Academy of Medicine prior to the pandemic that said 50%, at least 50% of caregivers across medical fields are reporting some serious symptoms of burnout, and that clinician well-being is essential for safe, high-quality patient care. So it was clear that if we wanted to continue to pursue our quality and safety goals, we had to take care of our caregivers in Virginia. And then along comes the Dr. Lorna Breen Foundation and Corey Feist, and that experience really it solidified our need to bring these two things together. And so we just sort of kept on that journey of a joint imperative to improve quality and safety meant a joint imperative to take care of our caregivers. And so that really is sort of what solidified our desire at the hospital association level to reach out to chief medical quality officers like Dr. Bundy and others across Virginia to come together to lead this work and to really participate in sort of a massive shared learning exercise.
Thank you. And it has been a privilege to work alongside both of you on this. Tell us more about the process of changing your credentialing applications. Joel, what advice do you have for other leaders getting started?
Yeah, what I would say is find out who in your organization oversees that. And that's really the heart of the matter. So in Centera, I actually oversee credentialing, I oversee peer review. So for me, it was a matter of me looking at those myself, figuring out, wow, I didn't know we were even asking those questions. And again, this isn't privileging. I mean, privileging belongs to the medical staff. These are those credentialing questions. So when we started talking about this, I looked through those from my level of leadership and said, we don't need to ask those questions. And so it was a very simple process of, if you know the person who has the ability to make those changes, assuming that they agree, that person can change those things immediately. So for us at Centera, it was overnight. I mean, it took us a couple of days and we were done, and we had removed all of those questions. Now we have an integrated delivery network, we have a health plan, we have a medical group. So then it was a matter of, okay, let me phone a friend over in the health plan. Tell me about the questions you asked. Let me phone another friend over in the medical group. What are you asking? And making sure that across the board that we have eliminated those stigmatizing questions. I would say though that always be diligent, because there are going to be forms and things out there that you didn't even think about that will come up in the future. But that's really what you have to do. Find the person that can make the change. You work with them, and you can do that very, very quickly.
Thank you. And I believe you set a land speed record for those first changes, and we appreciate your efforts on your clinicians' behalf. Abraham, thoughts on the process of changing credentialing applications and advice for getting started?
So two things I will state. One, I will echo what my colleague Joel Bundy indicated, finding out who is the organizational leader or champion with the authority to lead this effort and make these changes. We discovered, generally speaking, across the board in Virginia, it was a chief medical officer or someone with a comparable title. And so at the association level, we identified folks in our hospitals having that title and then leverage that responsibility. I would say in 99% of the cases, that was actually the correct individual. Secondly, understand the culture of your organization, its medical staff bylaws. God bless Dr. Bundy and Centera. I mean, they are a Virginia-based organization, and clearly when Dr. Bundy speaks, people listen. But that's one health system. We have other health systems who have a presence in Virginia, but they may be headquartered in a different state. We have other health systems in Virginia. They are 5 hospitals out of 150 across the country with headquarters in other states. So their ability to make the changes at the pace that Dr. Bundy and Centera made changes is just simply different. And so it was important for us that while we would like it to be a quick win, we had to be respectful of the organization's culture and how changes are made there. And so while some were able to do it practically overnight, there are others 6 months in that are still working through their process. So quick wins are nice, but don't go in assuming you will always have a quick win. And it's important to be respectful of the organization throughout the process, but continue to be persistent and diligent and driving toward the goal.
Thank you. In your experience, Joel, how has communicating about your hospital system, removing these intrusive questions from credentialing application, built trust with your workforce to access support if they need it?
Well, that's a great question. I would say that it was very, very, very important to tell the clinicians what we have done. We do lots of great work, and we often keep that in a bubble and don't share that with our physicians, our APPs, our nurses, or other people. So it was important to do so. I would say though that the other part of that is, okay, we've removed those stigmatizing questions, and we taught them, as Corey had said, we taught them, you're not going to lose your license, and then they're like, okay, well, what do we do now? So the other part of that is building something that they can use. I know that's not quite what we're talking about today, but the trust part is, okay, great, Joel, you fixed that. Do you have something that how am I going to get help? Are you going to help me with that? So, trying to build that confidential care pathway that you talked about, that's something that we are furiously working on right now.
Thank you. Changing credentialing questions is a little bit like that proverbial tree that falls in the woods. If nobody hears it, it doesn't make a sound. And so it's important for healthcare workers to know what has been changed on their behalf and what the access to resources is. Abraham, how does communication play a part in these rules for the workforce to access the support they may need?
There are things that health systems do that sort of have the appearance and are intended to support the healthcare workforce. Pizza parties, free coffee mugs with the organization's logo on it. There's an EAP program. There are even pay raises. And those things are often equated with helping the workforce be more resilient and showing appreciation. But the literature shows that all of those things, even the pay raises, the benefit is sort of limited short term. When you actually begin to look at systemic changes that contribute to the problem that these things are trying to respond to, that I think engenders a different kind of engagement from your workforce. And so all of those other things are important. So keep the pizza coming. We love the coffee mugs. We definitely like the raises. EAP is important, but start looking at the contributing factors and the systemic issues. And when you do that, communicate that as an effort to resolve and respond to the burnout issues. So do that work, but you also have to be intentional in connecting it to the pizza was to appreciate you, the pay raise was to appreciate you, and changing credentialing applications, you might not have seen that as visibly, but it was also done to support you. And so it's important to do that systemic work and to communicate it clearly as part of the larger effort to appreciate and support the workforce.
Thank you for those comments. Abraham and Joel, thank you both for this discussion. I always come away invigorated and excited for change to come. So I appreciate both of you. Right. As we move on through our webinar, we'll be discussing Action 4, communicating your commitment to professional well-being. And this is a two-way communication plan between the healthcare workforce and the leaders of the well-being work. And as we heard in step 2, the leaders of the well-being work will really incorporate and encompass different aspects of the healthcare workforce. So the key concept here is that clear, consistent, and open communication is an essential part of professional well-being. It is professional well-being work to establish communication, because communication builds trust between leaders and workers. It generates buy-in, creates opportunities for healthcare workers to identify those areas that require additional attention, and to really surface those as key areas of impact. So you'll see a link in the chat for Action 4, and I encourage you to open that and to look at that as we go along. The action item for Action 4 is to really outline a plan for communicating operational changes to staff, and then develop a two-way communication with the healthcare workforce about the well-being work and progress across a variety of channels. The expected outcome would be a communication plan that is shared among the professional well-being team and communicated to staff. So we want to make sure everyone knows what the status of the well-being work is. For those of you who have worked with a communications team before, you'll know that they'll often develop these communication plans and provide communication templates for leaders. And what we've done here is, in the resources provided, to really help move that work along by providing communication plan outlines, sample emails, meeting slides, and a leadership rounding form to guide conversation with the healthcare workforce to help to develop that two-way conversation. So really here, the importance of two-way conversation is to gather feedback and ideas from frontline workers. It was Muhammad Ali who said, "It's not the mountain ahead that will defeat you, it's the pebble in your shoe." And no one knows where those pebbles are and how to address them better than the people who experience them every day. So two-way communication really can serve as an essential way to understand what's happening in your organization and where those opportunities for improvement are. In the chat, you'll see a link to the tips for establishing two-way communication and well-being efforts, which I encourage you to download and follow along with. So the strategies to explore here include open dialogue and a culture of open communication, to establish formal two-way communication mechanisms, and to make shared governance a priority so that the entire healthcare workforce has an opportunity to raise questions and concerns, to ensure transparency and responsiveness, and to build trust through consistency in this communication, to cultivate champions networks, and to also cultivate support networks, and to recognize staff contributions and involvement to help encourage continued two-way communication. We have a communication plan outline, sample emails, meeting slides, contents, and leadership rounding forms available. And I encourage folks to look through these resources and to use what makes sense to incorporate into your organization. So we have put the templated emails, the samples, the links to those in the chat. And it can be immensely helpful to take some of the cognitive load of developing these resources off of your backs, and to really use these as a starting point in your communications. So it's important to really think through where the well-being efforts for your organization fit into the communication plan of your organization. There is almost certainly a communication plan around marketing, around how to get patients to your organization, how the organization is thought about in your community. There also needs to be thought about how you're communicating to the workforce about their well-being and how they should view their place in the organization and their importance, which is critical. So at this time, I'd like to welcome Bethany Friday and Jeremy Wooten to the stage to discuss the importance of healthcare leaders communicating that it's safe for healthcare workers to seek mental health care. Bethany and Jeremy, welcome.
Thank you.
We're thrilled to have you here.
Thanks. Thank you.
So we know that transparent, ongoing communication between leadership and healthcare workers builds trust. How have you created opportunities for staff input and communicated that it's safe for staff to seek mental health care? And Bethany, why don't you start with that answer?
Sure. So at our healthcare organization, every year, we're able to get buy-in and feedback from our team members of all entities, based on a well-being index survey that we do. It's system-wide, but we're also able to break it down based on facility as well. And then we also have another survey that we do, which we're actually currently in the midst of doing as we speak, which is our Great Place to Work survey as well. And within both of those surveys, team members they're asked about some well-being questions, but then there's also a free text at the end of the survey as well, which allows team members to provide any like additional information or maybe some additional resources that they would like to see our facilities do, new initiatives, etc. So we do, when we look at it more on the lines of a facility-based outline, which is done with our CNO and our wellness specialist. They kind of co-lead that together to give us the results. We're able to really see areas of strength that we're doing really well with our well-being and wellness needs here at our facility, and then also some areas that team members would like to see us improve on. So based on the results of the areas of improvement, our wellness consultant works alongside leadership, and then she also takes it down to the unit level as well and gets feedback and buy-in from team members of what they would like to see on ways to enhance our wellness and our well-being at our facility. And that's really how, we've been able to progress to, enhancing team members' well-being, really getting the word out there about mental health awareness and what resources we have here at our facility. One of our biggest resources that our wellness consultant touches on is a shared care app that we have, which is a system-wide app. So any team member, it doesn't matter who you are, is able to use it. It's free. It's similar to EAP, Employee Assistance Program. More facilities or organizations may know of it as that. But our team members do get 6 free sessions of mental health counseling, which is huge. And then anything thereafter, it's a very, very feasible fee for honestly any team member to be able to afford. And it's anyone in that household as well gets free 6 counseling sessions. So if you have, aunts, uncles, parents, grandparents, children, nieces and nephews that reside under your same address residence, then they qualify for those 6 free sessions as well, which has been a huge, very huge for us, because several of our team members have, communicated back to us, especially like with our elderly parents at times needing resources and them going through some of their barriers. The adolescents, a lot of parents with adolescent children definitely have several hindrances on both sides, right? The children don't know how to really communicate with their parents, and then vice versa, right? The parents aren't understanding kind of the new generation of how children are just behaving, interacting, etc. So that's really how our facility has been able to obtain input and communicate with our staff about mental health.
Thank you, Bethany. That sounds like a wonderful resource. And I know that, Jeremy, you are also bringing additional mental health resources to the healthcare workforce at your location. Can you share a bit about the well-being debriefs that you host?
Yeah, sure. So again, my name is Jeremy Wooten. I'm the clinical nurse leader here within the ICU at Wellstar Douglas. However, I am also a board certified psychiatric mental health nurse practitioner. And I'm in the process of transitioning into that role full time. So I have not yet started within that role, but mental health has always been just a huge passion of mine. So in between credentialing and all of that good stuff, I was like, how can I best utilize my expertise here at my facility, prior to me transitioning into full-time as a mental health provider. And, pretty much I kind of got the idea of, all right, if I can't impact patients here, let me impact my team, the people who touch the patients. And so, one of the main things that I really looked at it in terms of it being a debrief is that a lot of times we have debriefs after, traumatic events like codes or any kind of, hospital acquired issue that may happen, or an infection or a fall or something like that. But it's usually always operationally focused. It's always about the X's and O's. It's always about, okay, what technically went right and technically went wrong? Was equipment working right? Did we use the right processes, things of that nature? But we rarely talk about the emotional effects that has on the team, especially after traumatic events like codes and things of that nature. So that's why I kind of deemed it a well-being debrief. So it's almost pretty much kind of like a group therapy. We get together twice a month, and there are sessions that are topic focused. We talk about wellness and well-being. We talk about anxiety, depression, grief. We talk about trauma processing, and a various of other mental health components. And the entire objective is to destigmatize mental health and open up that conversation surrounding mental health, especially within the workplace. Working in healthcare, we work amongst some of the most horrible situations that you can face, right? Every day that we come in here, we're seeing someone at their absolute worst, and they're depending on us to aid them back to better health. So that can be a big burden to carry on your shoulders. And if you're not mentally equipped to handle that, it can weigh heavy on you. And I just wanted to open up that space to have those type of communications with the team, to let them know that we hear them and we're all going through these type of things together. And it just builds that camaraderie. It builds that that teamwork, that cohesiveness, that collaboration around mental health that really aids in destigmatizing mental health in itself. So that's kind of a little bit about our well-being debriefs.
Thank you. As we think about how to foster two-way communication, I'm wondering, what do you think about including leaders in these debriefs? Is that a good thing, or are there things to watch out for in that?
So initially it was kind of we was kind of up and down with it. We wanted to include the leaders because we didn't want them to feel left out, but at the same time we wanted to foster that open communication, that transparency, that authenticity from our frontline team members. And a lot of times people, talking about mental health in itself is tough. It's tough. And so we wanted it to be kind of like an even playing field. We didn't want anyone to feel like they couldn't open up around their, their immediate one-up or their director or their boss or whomever. So we wanted our frontline team members to be on one level playing field. Everybody is pretty much linear with their colleagues. So we have these sessions strictly for our frontline team members, and then we have additional sessions for our leaders, just so we don't leave them out as well. So so that's kind of how we navigated that process.
Excellent. Thanks for breaking that down for me. Bethany, how does your organization establish two-way communication outside of the surveys? And are there any strategies that you've identified as a sort of a best practice to really understand what's happening at the unit level?
So earlier I mentioned we have a wellness consultant. So she's really been, truthfully, like the best barrier to kind of get that two-way communication going at the unit level. She does staff meeting sessions with almost every unit and or department that we have at our facility. So on a monthly cadence, which is great. She does little mini breakout sessions similar-ish, but on a much smaller and quicker scale than Jeremy's. And definitely not as in-depth or anything, but it definitely gets, you know, people kind of coming out of their comfort zone a little bit, but it's a safe environment, asking questions, you know, but more about wellness, not so much focusing on people's like mental health portion of it. She'll kind of, an example might be like, what makes you smile at the end of the day, or what is one positive aspect of yourself, and like in one word, what is something positive you can say about yourself? So she's kind of been able to bring it down there. She also rounds on every shift, so we have 12-hour shifts here for our staff, nurses and care techs, etc. So she'll round on night shift and day shifts. She'll really have that one-on-one engagement with them, letting them know about like our mental health resources that we have here at our facility, and also that we have system-wide as well, which the staff have really loved, because unfortunately our system offers a lot of resources, but sometimes team members just don't know how to allocate those resources, where to obtain them, etc. So when she rounds, she's really able to do that one-on-one with the staff and just see where they're at. Also, team members will approach her while she's rounding, or sometimes just even email her or text her. She's very much an open book to us, which is great. And team members will just, you know, ask her like, you know, our unit, you know, and it may be amongst colleagues or, you know, patients, whatever it can be. And team members will just ask, you know, can you come to a huddle of ours and, you know, just do like a quick mental health, you know, kind of like reassociation of where we're at, you know, maybe a fun activity to kind of, you know, lighten the mood a little bit. And she's there, you know, she will, you know, try to come within that week if feasible with her schedule as well. And she'll also get with leadership too, though, to make sure that the leader, you know, is okay with that, which our leaders here are like, hey, whatever we can do to enhance the mental health of all of our team members, we're definitely, you know, 100% supportive of that. So that's really how we've been able to engage that two-way communication, really get the feedback and buy-in from the team members. It's really kind of driven through our wellness consultant from that aspect. But then you also have Jeremy as well, who, you know, is kind of that other life link to mental health that we have here too.
Thank you so much to both of you for sharing that sort of comprehensive approach of gathering information through one-on-ones, through surveys, and then offering resources at a variety of levels, right? At the level of the EAP, at the wellness consultant, through peer and professional peer support, Jeremy, through your sessions. Can you tell me also about the monthly wellness fairs at Wellstar Douglas and sort of what happens there at those?
Sure. So every month at Douglas, we do have a wellness fair, and different entities from the system come as well. So our wellness consultant, she has a table at our wellness fair. We've also in the past, which we are hoping to start also doing monthly as well, but just having a team member table that will sit next to our wellness consultant, so they'll kind of pair together on just different topics of just based on like different months of what team members are experiencing on their unit. We did, was it last summer or last fall? We did the suicide awareness table at our mental summer, yeah. We did that at our wellness table there, and it was phenomenal. So we had 2 team members who were care partners, nursing techs maybe for some others, that both had similar tattoos, and just like working on the unit, they both realized and it was the suicide awareness tattoo. So they realized, you know, we have the same tattoo, exactly what has occurred in your life that led you to obtain this tattoo. Come to find out, several more of our team members here have that in different departments as well. So they did actually approach our wellness consultant about it, and it was Suicide Awareness Month. So they asked her if they could do a table at the booth, or sorry, have a booth and a table at our fair. And of course, you know, she supported that. So 2 of our own team members ended up leading this table. They had different like wellness coloring books. One of them did, which actually sells on Amazon, which was awesome because we never knew that. And it has all of these like positive affirmation words amongst this coloring book for like, you know, wellness therapy, different support groups that they personally attend, and then just other support groups within our county as well, which is awesome. They even had some, I think, outside of our county as well. Different like hotline numbers, and then they were honestly open there, you know, to tell their stories, and then also how to support other team members going through this as well. So for us, you know, that was a huge eye-opening moment because so many of our team members suffer, you know, from suicide, rather if it's more on a personal level or just, you know, maybe even from an extension of that. And they were really able to capture each other's feelings and then work through it as well. And then we had other wellness booths at the fair as well, which also helped support them too. So it was wonderful.
Yeah. Thank you so much for sharing all that your organization is doing to support the mental health of the healthcare workforce and really establish those two-way communication mechanisms, Jeremy. And Bethany, appreciate you and all of your work on behalf of your healthcare workforce.
Thank you.
Thank you. And I just wanted to say thank you to all of the speakers for the generosity of your time and sharing the experiences of your organization and also taking our questions today.